Hi guys, so this is Tatum, and the other group members I've joining me is Allison and Addie. We focused our model discovery project on the SCOPIT model, which is known as the synthesis of child occupational performance and environment in time. Some origins to focus on throughout this model. It's based on the importance of occupation through the work of pioneers such as Riley, Yerxa, and Kielhofner. In this model, children are viewed as developing dynamically through participation in daily activities. So this model also discussed 6 assumptions, which are listed here. This includes that children are occupational and social beings. It also states that the use of occupation is the underlying foundation of occupational therapy and is equally important both as a means and as an ends. So occupation as a means involves the use of occupation as a therapeutic agent to promote transformation of the child, whereas occupation as an ends refers to the product of therapy and may include goals related to improving occupational performance. So a little example, occupation as a means would be like when the OT is treating a child, they may target the child's love for animals and use tasks involving animals like coloring images of an animal to improve the fine motor skills. Whereas if the OT is focusing the occupation on an ends, they would be utilizing the child's fine motor skills that they learned to work towards meeting the goal of taking care of the pet at home. So they're able to show this outside of therapy in their environment. Another assumption is that personal, environmental, social, cultural, and temporal factors influence occupational performance. Also, occupational development occurs through a dynamic process involving the drives and guided participation of the child. It also discusses that engagement in occupation brings about change and that occupational engagement influences health and well-being. So a little description of this model of practice. It looks at how a child's personal factors, motivation, and environment will impact their performance and activities. This impacts their overall participation in everyday activities. So for example, just like us, we are more motivated to do things that we find interest in. So a child would be more motivated to do an OT intervention surrounded by something they enjoy in an environment that they feel most comfortable in, as opposed to an unfamiliar environment that is focusing on an intervention surrounding a task or occupation that the child has no interest in. This model also shows an emphasis on improvement of occupational performance through maximizing the child's environment, which is fit within the scope of time. Some common terminology that's used throughout this model is synthesis of the child. This includes physical characteristics, psychological components, and the temporal child. Temporal context includes the features of the individual, which is things like age, developmental stage, life cycle, and health status. There's also occupational performance in time, which is a common term. This includes things like ADLs, work, leisure, play, and rest. Another term is environment. This includes temporal environment, physical settings, socio-cultural background. So the temporal features of a task would include things like sequential structure, duration, when the task takes place, rate of reoccurrence, and the structure. All of these terms help the therapist design evaluation and intervention strategies aimed at overall improvement of occupational performance. So here we have a little diagram that showcases this model. We found this in an article, and it also is described in our book that we utilize to learn more about this model. Shown here up above is a wristwatch, and it goes, if you read it left from right, it focuses on occupational performance, which is the focus of occupational therapy practice and is represented on the rim of the watch face. Child-related influences on occupational performance are listed on the left band of the watch, and environmental aspects are listed on the right of the watch. So the motivational factors are grouped as autonomy, relatedness, and competence, And the environmental factors are grouped as physical, sociocultural, and temporal. It also lists child-related factors, which is grouped as physical, psychological, and temporal factors as well. And then on the bottom of the picture, it represents the dynamic relationship between the child, motivation, and environment. This is essential to the Scopit model, and all of these influence each other, and they will have an impact on occupational performance regarding the skills, patterns, and domains. And then from here, it will impact outcomes, which includes the occupational performance, physical health, social inclusion, and well-being. The population that this model focuses on is children and all disabilities. It never really explains the most primary disabilities that are included within the model. So it's just children of all ages, so 1 to 18. This model also uses a top-down approach, as we learned in class. So the top-down approach in this model assesses the overall performance. The therapist considers the relationship between the child, environment, and occupational performance. So it helps to develop the intervention plan and to work toward adaptive occupational development and performance. This top-down approach considers function first, but doesn't lose sight of the underlying child factors that affect performance or the doing of an activity. So I also wanted to provide a top-down example so you guys could get more of a hint of what it means if you forgot. So if a client wants to return to school after an injury, the OT should start by assessing the client's ability to begin performing school-related tasks and then work on the special skills necessary to complete those tasks.
Now we're going to get into the evaluation and assessment part. So the Scopit does not currently have any assessments that are specific to Scopit. So we decided to look at a couple models of practice that are related to Scopit and then use their assessments or their related assessments. So one model of practice that we used to relate it to Scopit is PEOP. And we use PEOP because it takes into account the person, environment, occupation, and how those influence performance and participation. A key point in PEOP and Scopit is that activities in a child's natural environment help to foster autonomy and mastery of that particular skill. We also chose to use MOHO to relate it to Scopit, mainly for the volitional aspect of it, since motivation is such a big part of Scopit. So we use MOHO, and some examples of just like volition include a child wanting to ride his bike because it allows him to get places, or a child skipping rocks to see how far they can go to improve their occupational engagement. So those are just some things for volition. PEOP does also not have a set assessment with it, and MOHO doesn't either, so we decided to use the AMPS and PD. So the AMPS is the assessment of motor and process skills, and then the PD is Pediatric Evaluation of Disability Inventory. So first, getting into the AMPS, this is an observational assessment that measures the performance quality of tasks related to ADLs in a natural environment. It's designed to examine the interplay between the person, the ADL task, and the environment. So again, like the person, the occupation, and the environment. And then its psychometric properties include validity, having adequate predictive ability, and then reliability being strong iterator reliability. We got this information from the Shirley Ryan Ability Lab, so if you want to check out more of that, you guys can. Next is a sample of the AMPS. So since the AMPS was not a free assessment, we were unable to access it online, and the assessment room also didn't have it. So we just got a couple sheets from the internet, and mainly for scoring, not necessarily the exact assessment, but these show what scores are included on it. So, I mean, it'll give you a good impression of what the actual assessment measures do. So this is just the first part of the score form. It just makes note of the client's information, such as their name and diagnosis, everything you kind of needed to get before you start. It also lets the client rate the client's quality of performance there in the middle, along with baseline information and ability to live in the community. Since our clientele is mainly just pediatrics, the community part wouldn't be as important since they'd be living with an adult as if you were using this for like an adult. This next page is the second part of the scoring sheet, and it shows the different parts of both motor and process skills and what's measured in each part. So if you look at what's measured in each part, these align with what's in the OTPF, so they should all look pretty familiar. This assessment is also to be done in respect to the client's natural environment. Other than that, it didn't really address environment much more. The AMPS is scored with a range from 4 to 1 or 1 to 4, with 4 being competent and having no problems, 3 being questionable or having possible disruption, 2 as being ineffective and having clear disruption, and then 1 being severe or marked physical effort or fatigue, marked inefficiency, marked unsafe, or need for verbal and physical assistance. So based on whatever their task is, it can be graded with this sheet on how well they do it. The AMPS is related to Scope It in a few ways. Like we mentioned though, the AMPS is not the standardized assessment for the Scope It. So with that being said, it doesn't fully encompass all of the parts completely. It does hit the major parts of person, motivation, and environment, but like I said, some things could be lacking and, could be improved if there's assessment specifically made for the Scope It. With this, keep in mind that it can be with any ages, so sometimes it also doesn't align great since it's not with pediatrics specifically. For person, I guess I should also note that we put person, motivation, and environment for like how it relates, because these are the 3 main factors, again, if you've forgotten. So with person, it looks at the motor and process skills of the client's ADLs. Since ADLs are a big part of a person's daily routine, it can give a good example of something that is valuable to the client. It can also look at the client's body functions by looking at the ways they do ADLs, such as manipulation, coordination, and how they move. Those are all within the motor skills. And then in the process side, it can also look at the client's cognition for ADL tasks, such as sequence, organizing, and adjusting. So if you want to pause and go back to the diagram or the picture that's used for the Scope It, you can see that those are some things under the person part of the picture. So like, what their cognition is and what like their body functions are. For motivation, it looks at the quality of performance. So like I kind of highlighted on the first page of the scoring sheet, it does look at the quality of the performance, so such as like increased effort. So maybe if it's a lower effort rating on the scoring sheet, that might show that there's not as much motivation, whereas if it's a larger effort, such as like a 4, it can show that they had increased effort and maybe they were more motivated to do it. Otherwise, it doesn't really look at motivation much that we saw. And then for the environment, the environment's pretty much just looked at within the client's natural environment. And so the OT or whoever's doing the assessment will attempt to make the assessment most closely like the client's natural environment. And then this can show how the environment can inhibit or enhance a client's activity. That's all we have for the AMP. So we're going to move on to the PD. We kind of like to incorporate the PD with it because it is specifically for pediatrics. So with Scope It being also for pediatrics, I think that it ties in pretty well. The PD is, like I said, strictly a pediatric-based assessment. It is paper-based, and it can be administered via parent or caregiver report, structured interview, observation, or by professional judgment of therapists or teachers, or just by a combination of methods. So since it is strictly for peds, sometimes they aren't always going to want to participate like you want them to, or in the time that you want them to. So that's, I think it's a good thing that it can be parent or caregiver report as well, just so the assessment can be fully completed. The PD has 3 parts, so they include part 1 being functional skills, and it includes 197 items of functional skills. The part 2 has caregiver assistance and includes 20 items of complex functional activities. And then part 3 is modifications. It includes 20 items of complex functional activities. So you'll see this in just a second, what the different parts are, but I think that personally, I think that this assessment is really cool because it does look at the assistance and modification level, whereas a lot of assessments don't explicitly look at that. So I think it's cool that it's already addressing the environment and modifications that are needed to help the child be the most successful that they can be. For the psychometric properties, it's, the gold standard for peds. So there's been a lot of research on it and information to back it up. So there's a lot of psychometric properties. These are also found on Shirley Ryan Ability Lab. So for validity, it was reported that there's strong content validity, excellent concurrent validity, and excellent convergent validity. For reliability, it's reported that there's excellent inter-rater reliability. And for sensitivity, it's reported that it is sensitive to changes in function over time. This is just a sample of the PD. This is the self-care domain that you can see up in the top left. So this is part 1 of functional skills like we talked about. You can see here that it is kind of lengthy. So again, with it being caregiver report as well, that's nice because at the end of it, the child might get bored of performing these tasks or not, perform every single one of them. So it measures ADL such as eating, washing self, dressing, toileting, and more that you can see. The assessment looks at the ability of the task instead of individual parts of it. So for example, it looks at the child washing their body instead of their range of motion. So it's very much a top-down approach since it's looking at the activity as a whole versus how they do it. There are also mobility and social domains within this part 1. But for safe space and copyright issues, we did not add them. So if you're interested in looking at more of the assessment, you can let one of us know. We have in the assessment room if need be. This is another page of the PD, specifically being parts 2 and 3, so caregiver assistance and modification. So this is kind of, like I said, looking at the environmental aspect. For each domain, self-care, mobility, and social, it looks at what assistance is needed or what modifications are needed. So these are ranked on the scale you can see 5 to 0, or with the letters none, child, rehab, or extensive. So like I said, this is just cool because it looks at how things such as a wheelchair can impact someone's mobility. And, make the child more successful in their environment. The PD relates to Scope It decently well too. So it looks at the person by looking at 3 domains of a person, including self-care, mobility, and socialization. All people have some level of self-care, mobility, and socialization with their life, and so these are most likely valuable to the person. So it helps to measure their psychological component mentioned in the picture of the Scope It. It also addresses the physical component of a person by looking at to what degree their body structures and functions allow them to complete tasks. The PD also addresses motivation to some degree by looking at what domains that people find value in. So other than that, autonomy, relatedness, and competence are not measured greatly by the PD. So that's one way having a Scope It specific assessment could benefit. And then we also, like I said before, we liked the environmental component of this since it looks at the modification and support in the environment. So I think that's a really big part of this model. Scope It's related to OT in general by looking at the child's occupational performance in the following areas, such as ADLs, play or leisure, rest, and work. Scope It emphasizes the effort and choice of the child based on the environment, child's motivation, and the temporal factors that contribute to occupational performance. To use the Scope It in everyday practice, it's used with a holistic and client-centered approach, which is occupation-based. So that's one way it could be used in OT practice. As we all know, we kind of like the holistic side and treating, the client where, they need to be within their tasks and daily life. So I think the Scope It does a really good job with that. OTs can also utilize intrinsic and extrinsic motivators to support the child's engagement, in turn maximizing occupational development and performance in their environment. And then OTs can also work with the child to foster autonomy and mastery. They can do this through affirming environments, education of the child, caregivers, and teachers, the use of occupation-based interventions in natural environments, the selection, creation, and modification of the task to fit the child, and the use of interventions designed to adapt and create empowering environments.
Although there weren't any specific limitations listed for this model of practice, we kind of just chose different ones that we thought would be a limitation based on the research that we did. The first is that the population is only specific to pediatrics. Although it seems like a really holistic approach, it hasn't been applied to any other ages, so it's kind of hard to tell what would happen in those situations. It does not have a standardized assessment linked to the models of practice, so like we said, we had to look at other models of practice and different assessments to try and find one that would be applicable. And then it does not have a guide to an intervention plan. So it doesn't really take you into an intervention, but it's able to look at the different aspects of why or why not a child is wanting to participate in specific occupations, and then it's not widely used. And then because it isn't widely used, it was kind of hard to find a lot of different case studies that were talking about the Scope It. So instead, I found like the first couple of articles that were used by the author, and then one at the end was an actual case study. So the first one talks about children with developmental coordination disorders and how they're less physically active and have significantly different patterns of social and physical play than their well-coordinated peers. So it broke it down how the Scope It does on the temporal, environmental, and then child level. So at the temporal level, children with DCD value working over play. So instead of wanting to go outside and participate in physical activity, they like to be in more sedentary environments where there's parental supervision, where they feel like what they're doing has a purpose opposed to just going outside to play. Because of valuing work over play, there is a huge occupational imbalance in children with DCD. And so that's just something that we need to look at as occupational therapists. And then another thing that they found is there is a huge loss of involvement in team activity. This could be due to a lot of different reasons, but they also found that children that do participate in team activity from a young age are more likely to stop participating in that team activity around the age of 8 compared to other children. In the environmental level, one of the big factors that children with DCD are less physically active is from a socioeconomic factor. This could be because they're unable to purchase a lot of the necessary things needed to participate in the sports, or they're just in an environment that might not have access to as many of those sports, different things like that. Another one was family belief and ego. So they found that if families had like this huge competitive drive behind them, or they have like a huge ego behind sports, children are less likely to want to participate in different physical activity or even team sports because they're afraid of failing. So they would much rather not even attempt to participate in physical activity instead of failing in the activity. Another environmental level issue would be peer influence. So because they are almost like, they know that they have coordination issues, so they are kind of embarrassed by them and they don't want to participate with their peers or be looked at in a different way. So this could impact their like social circle and different things like that, and kind of steer them even further away from participating in any physical activity. And then at the child level, this article mentioned that there was a higher imbalance in physical activity in boys than there was in girls. And then they kind of took this and said that this could contribute to like hegemonic masculinity in a different way, just because a lot of times from a young age, boys kind of center their masculinity around their participation in physical activity. Another reason that children weren't participating in physical activity was because of their unnecessary movements causing decreased enjoyment. So it was a lot harder for them because they were doing a whole bunch of movements that weren't effective, and it just caused them to be more upset with how the situation was going. And then because of this, children have higher anxiety and lower self-efficacy, especially when it comes to physical activity, because they know that they don't look the same as the other kids participating in the sports. So it really stresses them out, especially when they know they have to go do physical activity later in the day. And then they also found that this anxiety and low self-efficacy doesn't go away, even as they age up and potentially grow out of this disorder or improve in their coordination. They still have anxiety and low self-efficacy when it comes to different things. So the big premise of this article was the scope it conceptualizes the multiple dimensions which impinge on the decisions to select, engage, and persist in physical activities for children with developmental disorders. I thought it was really cool because it broke down why these children are not engaging in that physical activity as much as other children, and it just like we were saying earlier, took a holistic approach to it all. All right. The second article that I found presented the risks of physical inactivity in children, and then described the factors influencing inactivity using the SCOPE-IT. So in this article, they started out by saying that it was originally found that children needed to experience 30 minutes of physical activity for 3 to 4 times a week. But then later they mentioned that more research has found that children should be participating in physical activity for 60 minutes a day. And with this, children should be in a controlled environment for only 10 to 15 minutes, and then should have a 30-minute activity break following that controlled environment. And like we found in the last article, especially in children with DCD, it's hard for them to experience this break. So with the Scope It, they broke it down into only a child and an environmental level this time. So at the child level, there were different personal characteristics that got in the way of physical inactivity. Some of those patterns included age, gender, motor coordination, and then physical fitness. The next one was intrinsic motivation. So they summed this up to being like choice, effort, and then persistence. And they said that these are adaptive outcomes of activity engagement that are associated with increased intrinsic motivation and positive physical activity experiences. And then allowing for these children to have the choice encourages the development of self-regulation associated with self-determined motivation to learn and accomplish and experience enjoyment in those physical activities. And then the last one at the child level would be experiences. So if they had a positive experience with physical activity, they're going to want to continue to do it. But if they have a negative experience, they're obviously going to want to stray away from it. And then at the environmental level, there are different physical barriers. So again, if children didn't have the right environment to participate in physical activity, either at home or in a team setting, it's going to prevent them from being able to do it. So they talked about at home kind of providing them a safe space to go and do physical activities instead of limiting them to sedentary activity all the time. The next factor was social and cultural at the environmental level. And again, this just kind of looked at children not being able to participate in those sports due to like economic reasons, and then their like school not giving them a proper opportunity to participate in those activities and only making it like a competitive environment instead of a place where they can like practice their skills. And then the last one again was parental. So if parents kind of have a specific outlook on physical activity at the beginning of their life, the children aren't really going to want to do it. So it's really important for them to provide like a positive environment and a way for them to practice their skills in like a non-judgmental way, so then that they're willing to continue to participate in it. And then for this one, the Scope It model was used to describe the complex interpersonal and intrapersonal and temporal influences on physically active patterns of occupational behavior. This model allows for a systematic explanation of multi-dimensional activities. And then for the last one, it was actually a case study. And then this one was done at the University of Toledo. It was a third year's, and I believe 2013. So in this case study, it was a 6-year-old with Down syndrome. When they went to meet with them, they collected info through home interviews and observation. This observation took place at home, in school, and then with peers. And they found a lot of deficits with work, activities of daily living, and then social participation. So here they were looking at a way to develop a home program to increase performance in ADLs, work, rest, leisure, and play. So with this home program, they started out by listing a whole bunch of different goals. These goals touched on a lot of different things about like being more independent in therapy, contributing to more chores at home, and then being able to dress himself before going to school. And one of the example goals that they had was by the end of the 4 weeks, Jason will don 2 items of clothing with minimum physical assistance in 4 to 7 opportunities. So these goals and observation were followed by a 4-week home program with parental education. So with this home program, they made a lot of different visuals. So when it came to dressing, they had a little visual with cutouts of shirts and pants of different colors, and they put Velcro on the back of him, and he was able to like pick out a shirt and pick out a pants to see what that would look like on the stick figure on the thing. So then he could go and dress himself based on that. And then during this 4-week home program, the dad was supposed to do the documentation. So at the end of each day, he would record how much assistance Jason needed in the opportunities based on a specific sticker. And so by the end of the 4-week program, there was an increase in occupational performance across all domains, including setting the table, picking outfits, and then increased independent and school OT sessions. So again, there weren't any specific assessments that they really used. It was just collecting through observation, interviews, and then just letting him go about his daily life with the different visuals that they implemented. And although they didn't reach as many of their long-term goals, a lot of their short-term goals were checked off and then exceeded, which was really cool. But yeah, that is the summary of the Scope It. Like we said, it's a holistic approach with not as much focus on intervention, but just kind of looking at the reason behind why children are how children are interacting in their occupations based on the different contexts behind them.